welcome you all in Mystifying Medicine. Today we discuss about pneumothorax from our past medicine notes in respiratory series. So what is pneumothorax? Pneumothorax is actually the entrapment of air into the pleural space. Here you can see in this figure there is a air that is entrapped between lung tissue and the pleura. Pneumothorax classified into the three: primary, secondary, or iatrogenic or traumatic. Primary, when there is no underlying lung disease but air escape from the lung into the pleural space through the rupture of small subpleural emphysematous bulla or pleural blebs, or air escape through the pulmonary end of pleural adhesions. In this, there is no any primary lung pathology, so that's why it's known as a primary. Secondary, the underlying lung disease, most commonly COPD and TB, asthma, lung abscess, pulmonary infarcts, bronchogenic carcinoma, or all forms of fibrotic and the cystic lung disease. And iatrogenic, following by the pleural biopsy or thoracic surgery or any chest wall deformity occur due to the trauma, so that's known as the traumatic or the iatrogenic pneumothorax. So what are the clinical features in past medicine? We discuss about the past medicine. Now what are the features of pneumothorax? Risk factor: pre-existing lung disease, either COPD, asthma, cystic fibrosis, or lung cancer. This is known as the secondary pneumothorax or pneumocystic pneumonia. Connective tissue disease like Marfan syndrome, in this there is a collagen or other deficiencies that weakens the pleura and causes the pneumothorax. And in rheumatoid arthritis, there are autoimmune diseases that also act against the pleura and causes the pneumothorax. Ventilation, including non-invasive ventilation, that may cause the iatrogenic pneumothorax. The most important, it is in RCP questions. RCP questions is catamenial pneumothorax. You may see in the past medicine BCQs that there is a catamenial pneumothorax is a type of the spontaneous pneumothorax that occur in the menstruating movement. It is thought to be caused by endometriosis within the thorax. When a woman is in menstruating cycle occurs, patient may develop the catamenial pneumothorax. The symptoms tend to come on suddenly. Features include dyspnea, chest pain, often pleuritic, sweating, tachypnea, and tachycardia. The chest pain that occurs suddenly is of pulmonary embolism, and second one is of pneumothorax. It is a severe sharp cutting pain occur in chest. Here you can see in this figure there's a air that is shown to be the jet black color, and this is a normal lung tissue. Remember, the air on the chest x-ray looks to be the jet black, bone more white. In this figure there is a pneumothorax, and this is a normal tissue. So what is the management of pneumothorax? Firstly, I discussed this flow chart. Pneumothorax confirmed on the chest radiograph. When patient came with these symptoms like chest pain, tachypnea, tachycardia, go for the chest x-ray. If chest x-ray confirm the pneumothorax, then see for these 2 or 3 things. Firstly, if patient has a known lung disease, patient age is more than 50 years, or with a significant history of smoking, either he is a smoker or non-smoker. If there's no any lung disease, or patient is not more than 50 years and there's no any lung history, that is known as a primary pneumothorax. And if these histories are present, then these known as the secondary pneumothorax. Then the size of pneumothorax. If size is more than 2 centimeter and patient is symptomatic like breathlessness, then aspiration should be attempted. And if patient is not short of breath and size is not more than 2 centimeter, then discharge the patient and call for follow-up. And if more than 2 centimeter and patient has shortness of breath and you aspirate the air, if it is successful, discharge to the home. If it fails, then put the chest tube. And on the other hand, the secondary pneumothorax, that always requires admission, because secondary pneumothorax, there is a tendency to expand the pneumothorax, and patient may worsen or may develop the tension pneumothorax or obstructive shock. So it is more dangerous. So always requires admission and observation for 24 hours. If secondary pneumothorax is more than 2 centimeter, or patient has a shortness of breath, or both, if yes, then put on the chest ring. And if patient size of pneumothorax is not more than 2 centimeter and patient is not symptomatic, then aspiration or observation is required for minimum for 24 hours, or supply oxygen. So this is the BTS guideline for spontaneous pneumothorax. If rim of air is less than 2 centimeter and patient is not shortness of breath, patient has no shortness of breath, then discharge to the home. Otherwise, aspiration should be attempted. If fails, defined as the more than 2 centimeter and patient has a shortness of breath, chest tube should be inserted. If less than 2 centimeter, not short of breath, discharge to home. If more than 2 centimeter and shortness of breath and has shortness of breath, then aspiration should be attempted. If aspiration fails, then chest tube should be inserted. And other is a secondary pneumothorax. Always ask age is important. If more than 50 years and there is a rim of more than 2 centimeter, put the chest tube. And aspiration should be attempted. If it fails, or if between 1 to 2 centimeter and aspiration fails, again put the chest tube. And if it is less than 1 centimeter, then admit the patient to the hospital and give oxygen. Other one is a iatrogenic pneumothorax that mostly occur. It is a likelihood of reoccurrence than spontaneous pneumothorax. Majority will resolve with observation. If treatment is required, then aspiration should be used. In ventilated patient, it needs the chest drain. Mostly the COPD patients. Discharge advice: you should advise the patient to quit the smoking, because pneumothorax is 10% more the patient who is smoker is more at risk than non-smoker. Non-smoker has a risk of 0.1 and the smoker has a 10%. Otherwise, is a fitness to fly. Absolute contraindication is not to travel more than 2 weeks, but now it is recommended to 1 week post chest x-ray. The familiar topic is chest drain. The chest drain is a tube inserted in the pleural cavity which creates a one-way valve, allows the movement of air or the liquid out of the cavity. So their indications are pleural effusion, pneumothorax, that not suitable for conservative management or the aspiration, empyema, pneumothorax, chylothorax, are in some penetrating chest wall injuries in the ventilated patients. Insertion of chest drain is relatively contraindicated in the patient. These are the indications and these are the contraindications. If patient INR is more than 1.3, he may bleed, or platelet count less than 75, or there is a pulmonary bulla, because if we put the chest drain, bulla will further rupture and may deteriorate the further condition. So pulmonary bulla, it is relatively contraindicated, are pleural adherence. So if once a patient, so there's a procedure. Once patient consent has been obtained and patient imaging assessed, the patient should be positioned in the supine position at the 45 angle with forearms positioned behind the head to allow easy access to the axilla, in which space fifth intercostal space at the mid axillary line. Fifth intercostal space in the mid axillary line position may be determined. So how can we confirm that it is placed properly? Position can be confirmed by aspiration of fluid or the drainage in the tubing, or swinging of fluid within the drain tubing within the patient inspires and on the chest x-ray. Means you ask the patient to cuff. If column is moving with the cuff or with the respiration, means tube is placed in proper position. What are the complications? Complication may be patient may not give the consent, or failure of insertion, means you put the chest x-ray and it goes to the hit to the lung or into the abdominal cavity, so you should remove and reset it. Bleeding may occur, infection, penetration to the lung, or re-expansion pulmonary edema. Remember this, because most of the patients face this and this is the acute condition. Re-expansion pulmonary edema may be preceded by the onset of cough and shortness of breath. In the event of concern regarding re-expansion pulmonary edema, the chest drain should be clamped and urgent chest x-ray should be obtained to avoid re-expansion pulmonary edema. In this patient, when you put the chest tube and patient develops sudden shortness of breath and the cough, you may think about the re-expansion pulmonary edema, and for preventing this, you should clamp the regularly with rapid fluid output at a time when you put the drain. If it is a massive pleural effusion, drain it not rapidly, whole of the amount, slowly and gradually, to prevent from the re-expansion pulmonary edema. Output should not be exceed 1 liter of fluid over the short period of time, less than 6 hours. So when to remove the chest x-ray? When insertion indication is completed, like fluid drainage of pleural cavity, drain should be removed when